general program, and the other group is just, pre and post. We're going to talk to them and kind of give them the information needed to move on. And then in the end, that's going to help increase their self-efficacy and also adherence to exercise changes, to their behavioral changes. Okay? So looking at the aim of the study, just to kind of reiterate, we will develop that intervention, okay, that helps them increase exercise and diet. Okay? Again, these women have tested positive for breast cancer. Okay? Looking at aim 1, okay, the main goal, to increase their knowledge of the increased risk. Okay? And the second goal is to utilize the individualized program that they're getting, whether it's an individualized program, a general program, or a program or no program at all, and help them decrease their BMI rates and increase self-efficacy among the awareness of the participants. Remember, this is a 6-month study, so our goal is to hopefully motivate them. Okay, so when we look at complications, when we look at the alternative plan, there can be a lot of complications anytime that you do a study. Okay, participants just, in terms of complications, participants just don't want to do it anymore. They're not motivated. Okay, for whatever reason. Yeah, we're offering compensation, but for some people, monetary is not the goal. Okay, the clinical environment. We've chosen to use 3 sites. Okay. Maybe the person feels comfortable being out at a park or being at a gym, a gym like Curves, or somewhere where it's a little bit more neutral, a neutral site. So there can be some bias there. Not enough adequate space. Remember, we have 50 people per group. Now, are we going to have all 50 people at one time? No, but there could be an issue with space. So spacing, also lack of motivation. Okay? It's our goal as the clinician doing the study to motivate these individuals. And especially over a 6-month period, a lot of the research out there shows, to really have a successful program, we want you a little over 25% completion. Of course, our goal is we want everybody to go through that. Now, in terms of an alternative plan, again, changing the location. Because sometimes when you think about a clinical environment, or we think about a hospital, what do we think about? We associate the hospital with people being sick. We think of death. Those types of things also, that throws motivation out the window. Also, maybe the hospital, the location of town where the hospital is, maybe is the clinic old? Is the hospital old? So right there, these people already have a preconceived notion that they don't want to do it. So to provide a warmer and friendly environment. More individual support. We are going to hire some health educators to come in and do the interventions, but we might have to hire more individuals. So again, hire more clinicians, and then again, a natural site like there's a cooperating fitness center, a park, somewhere that's neutral and gets everybody away from that stereotype of hospitals and clinics being scary per se. Not for everybody, but for most. So as Heather mentioned, we do have 3 groups. Okay, this is a 6-month intervention. Group 1. Think of group 1 as, they're getting all the nuts and bolts. They're getting the full package. So they're going to go in, they're going to get their genomic testing, which is not cheap to do. It can be very costly. And then we're going to read them their results. So they got their results, they know they have it. Okay, they're going to go in, they're going to do that health history form as Heather mentioned. We want to make sure A through Z, what else do they have? What's their family history? Okay. I also want to go in and have them do a pre and post fitness assessment. So I want to not only look at, do they have a family history of cardiovascular disease or diabetes, but I want to know what's your BMI. I want to know how flexible you are. I want to know how strong you are. So with that being said, we're going to do a pre and post and compare those numbers. Okay? Because, we always told people it's not where you start, it's where you finish. Now with these consultations, we're going to be hands-on with them, real hands-on with them. We're going to be every week on Tuesdays and Thursdays. And just to keep them motivated. Now in terms of the dietary piece, we're going to come in pre, mid, and post, and we're going to make sure that we stay on board. So with this being a 6-month study, we'll come in at the first month, we'll come in right after the second month, or right around there, every 2 months, and we'll do that. Not only are they going to get the nutritional information, they're going to get a consultation, they're going to get a one-on-one, and then off of that they will have an individualized nutritional program based off of their results of their test. Okay. Also, with that being said, to take it one step further, they're going to get individualized exercise prescription based on their results as well. just to work with them, and that'll be pre, mid, and post. And then this, of course, at the end, they're going to get some methods, just some information on what to do in terms of to decrease the risk, some helpful information, and also some links and websites and things that we have put together for them. Now, Group 2, on the other hand, yeah, they're going to get some of the same things as Group 1, but Group 2 is going to come in. Yes, they're going to get their testing. They already know that they have it, but they're going to get a generalized program. So think of Group 1 as more specific, more individualized. This is the general group. Okay. Same thing. They're going to have the health history form. They're going to have a pre and post assessment. Still want to have them do an assessment, but in terms of the exercise prescription and the nutrition, we're going to base the information off. It's very general. We're going to give them very basic general information. On the exercise piece too, very basic exercise information, telling them what to do, but it's not going to be a customized program. And then in the end, this group is also going to get the methods at the end. Now with Group 3 being the control group, okay, they're just going to get the methods at the end. So that's it. Okay. So Groups 1 and 2. Group 1 being more of the general group, or Group 1 being the more specific group, all the nuts and bolts, all the the bells and whistles. Group 2 is more general, and then Group 3 being the control group, not as much. So if you look here, it's just a visual representation in terms of the timeline. It breaks it down. Of course, we have 150 participants that will be tested for the BRCA1 intervention. Okay, they'll have the test done. They'll find out that they have it or not. So they have it. Group 3 will go. Groups 1 and 2 and 3 will have their health history form, all the things that we talked about in terms of the questionnaire, the dietary plan. Now, in terms of the specifics, as I mentioned previously on the previous slide, they'll go in and they'll have the dietary program, the workout plan. All 3 groups will have the decreased risk diagnosis and pamphlets of information given to them. And then lastly, Group 2 will have 2 general pieces, the general exercise prescription and the dietary program based on guidelines. Okay. So future direction, depending on what we find out, as Heather mentioned, there's no research really done in this area, so we want to look at other things. Of course, anytime you do a study, you want to sit back and reflect and see what the results show you. Maybe it's picking a different location, as I mentioned, other than a hospital. Remember, hospitals are associated with people being sick. Maybe somebody had a bad experience where they lost a family member in the hospital, or they were in the hospital for a long period of time. So asking them to participate in a clinical research study, whether it's in a clinic or a hospital, they've already turned themselves off mentally because of that. Okay, and also in terms of the hospital reputation, there's different hospitals within certain cities and towns that might not have as good reputation. So ourselves as the clinician, or the clinicians doing the study, we want to make sure that that homework is done, that we work with a group that has a lot of respect. Lastly, we would like to provide a program that coincides with current city initiatives. A lot of, for example, in San Antonio, there's a lot of city initiatives that focus on decreasing BMI, increasing physical activity, Slacovia, fitness in the park through the Mayor's Fitness Council, Get Fit San Antonio. And that way, if you can tie it in with a certain program that's going on, your individuals participating in the study would probably be more inclined, more motivated to do it from that regards, because they might have had a family member who they lost to breast cancer. You have the Susan B. Komen, and that's something that's very passionate to them. So they're going to be more likely to participate in that research study. And these are our sources here. And do you guys have any questions? Well, we want to personally thank you all for coming out today, and have a good weekend.
Yes, I have a question.
Sure.
Can you tell me what the cost of genome testing is? And also, could you define genome testing?
Sure, I can give you the budget breakdown.
Let me,
Go ahead, you want to answer
yeah.
that first?
Let me,
that first part?
before we start talking about cost of genome testing, let me explain what genome testing is and what it does. Genome testing is actually identifying DNA strands within an individual's makeup. The idea of identifying these genome strands is to be able to identify different loci that are associated with an individual's likelihood of developing an outcome, a physiological outcome. So when we look at breast cancer and we see the cell manipulation, is it in the strand, the DNA strand, that there is a loci that identifies this manipulation within the cell? We can also look at genome testing in a sense of, when we look at exercise prescription, we can look at it in the sense of the type of muscle fiber that they are. So perhaps what we're doing is we're looking at, are they a fast twitch muscle type? And if they're a fast twitch muscle type, then with our exercise prescription expertise, we can then develop workout programs that are specific to a fast twitch muscle type. But it's not just for in the areas of breast cancer for cell manipulation or exercise. We're starting to see genome testing across the board for multitudes of different types of things. Likelihood of diabetes, we're seeing loci associated with diabetes risks. We also see loci associated with mental health issues. So the idea here is to take this DNA strand and identify the different loci within this DNA strand, and if it's in there, then that puts that individual at risk, and that's what we would be testing for these first degree relatives as well. Yeah.
In terms of just the price, doing the research, whether it was on the genome websites, various government websites, medical websites, you know, depending if the person has insurance or not. That's why a lot of people aren't doing this, because it's very expensive. I saw it as little as $100 with really good insurance to all the way up to $2,500. So if you have a large study, say our study, we're asking for a little over $500,000 to execute this study. So if that's the case, you take 150 people, and we projected about $1,500 per person. So you take $1,500 times 150 people. It gets very expensive real quick. So a majority of the money that you need to allocate towards your study is done with the genome testing. It's more expensive than even hiring your staff, your clinicians, to do this 6-month study. Any other questions? Thank you very much.